Good afternoon, and thank you for joining us today on our webinar, Advancing Health Equity, a Community Discussion for Rare Disease Day. My name is Alicia Lawrence, and I am the Patient Services Case Manager in the Patient Services Department at NORD. And it is my pleasure to be your host for today's webinar. We're so glad that you've joined us today. This webinar is one of NORD's Rare Disease Day events for 2021. There are many other Rare Disease Day events taking place over the next several days. If you haven't already done so, I would encourage you to visit NORD's website to see whether there are other events that you might be interested in. As a social worker and the Patient Services Case Manager at NORD, I work closely with patients and caregivers who are experiencing inequities in access to the treatments their physicians want them to have. In my role, I am the lead provider of quality information and resource services for the rare disease community. And I've also been working in the field of social work for over 20 years and have held various positions in hospitals as well as community-based agencies. In our patient services department, we receive about 6,000 calls in a typical month, and often these are individuals who are in very desperate circumstances and have nowhere else to turn for help. Our topic today reflects that people with rare diseases often have limited access to diagnosis, treatment, and care, and the disparities that can be even greater for people from underrepresented racial, ethnic, and other minority groups. Healthcare equity is one of the underlying themes for Rare Disease Day, and NORD is honored to have a panel of speakers today who can address the topic from various perspectives. Our speakers are as follows. First, we have Beverly Francis Gibson. She's the president and CEO of the Sickle Cell Disease Association of America. Next, we have Dr. Kirk Campbell, Associate Professor of Nephrology and Vice Chair of Diversity and Inclusion at the Icahn School of Medicine at Mount Sinai. Next, we have Ashley Whited, a first-year medical student at the University of Pittsburgh School of Medicine. And last but not least, Pam Gavin, who is our Chief Strategy Officer here at NORD. Before we get started, just a brief word about NORD. For over 30 years, NORD has led the fight to improve the lives of those with rare diseases. We do this through education, research, advocacy, and patient services. To learn more about NORD or to access our resources and events, please visit rarediseases.org, and you can also follow NORD on Instagram, Facebook, and Twitter. The webinar is being recorded and will be available to all registrants in the next few weeks. At that time, please feel free to share this with anyone who has not been able to join us today. This is an important topic, and our hope is to include as many viewpoints as possible in this ongoing conversation. Many of you who registered for this webinar included questions that would like to hear discussed. We'll get to as many of those as we can. And in addition, if you're watching this webinar live and using the Global Meet browser, you can submit questions through the Q&A function at any time during the conversation. We'll get to as many of those as we can. Now, I'd like to get started by asking each of our panelists to take a few minutes to briefly talk about what they do and to share their perspective on the current issues related to health equity and how they feel health equity can be advanced. Beverly, let's get started with you, and then we'll hear from Kirk, Ashley, and Pam. Please just tell us a bit about what you do and how it relates to today's topic.
Thank you, Alicia, and I am happy to be here. Hi, everyone. I am Beverly Francis Gibson, President and CEO of the Sickle Cell Disease Association of America. In my role, we support sickle cell patients and their families to access care across the United States. We are very involved in legislative and advocacy efforts to also ensure that sickle cell patients receive the benefits of services in their local communities. We also have 53 member organizations across the country, and we provide leadership, academy, and capacity building resources to assist them in the work that they do every day. The reason that I wanted to be a part of this conversation today and really appreciate the invitation is because we know that there have been health disparities in this country for a very long time. I believe, however, that the COVID vaccine pandemic situation has elevated and highlighted some of the disparities that many of our patients who are facing rare diseases experience every day across this country. And I applaud NORD for being a part of the movement to bring this to the forefront and to have conversations like this with the rare disease community. So I thank you for having me today, and I look forward to the discussion.
Great, thank you. Kirk, you want to go next?
Yeah, thanks so much. And I echo Beverly's sentiments in being thankful for being included in this excellent webinar. So I'm Kirk Campbell. I am an adult nephrologist, kidney doctor here at Mount Sinai in New York, where I'm also the Fellowship Training Program Director. And I'm the Vice Chair for Diversity, Equity, and Inclusion, Department of Medicine. I am a physician scientist, very active in developing novel approaches to rare kidney disease. So I do have an interest in the medical education, clinical trials infrastructure, which of course is one that's very important to view from an equity lens with the disparity in participation in clinical trials for patients from underrepresented groups. As a part of my role in the Department of Medicine, I'm also responsible for some of the educational initiatives really geared towards increasing knowledge regarding implicit bias and how that can have an impact negatively on clinical outcomes. So we do track clinical outcomes from a quality improvement perspective at that level as well. So once again, thank you for the invitation. I look forward to a great discussion.
Great, thank you. Ashley?
Hi, thank you, Alicia. Again, echoing everyone else, I am very pleased to be here, excited to talk about my experiences and my perspectives. So a little bit about me. I did my undergraduate and graduate schooling at the University of Pittsburgh. And after completing those degrees, I started working in rare diseases at Children's Hospital of Pittsburgh, in rare neurodegenerative disorders, including leukodystrophies and other storage disorders. And so that's where I was really first exposed to the clinical side of the rare disease world. And as someone who also struggled with a rare disease, I kind of understand the patient perspective as well. And now I'm a first-year medical student at the University of Pittsburgh School of Medicine. And I was blessed to be part of a panel of students that came together to help write an oath to supplement our Hippocratic Oath. The Hippocratic Oath doesn't address a lot of the really important issues in medicine that, the general population as well as the rare disease world is facing. So some of those themes that we included BIPOC or Black, Indigenous, people of color, Women X, interdisciplinary collaboration, physician responsibilities, mentorship and research, the importance of narrative medicine, as well as the social determinants of health and advocacy for those. So I'm really hoping to act as an advocate in the future as a healthcare professional.
Great, thank you so much. And last but not least, Pam.
Thank you, Alicia. It's a pleasure to be here with this esteemed panel today to talk about this very, very important topic. I come to NORD as a healthcare professional, previously focused on improving healthcare quality outcomes for patients, a patient safety advocate, and a member of the rare disease community, leukodystrophy, metachromatic leukodystrophy in particular. So coming to NORD, it's a blessing to be able to work on in an area that is really focused or blending my personal and my professional experiences together. And in my current role, I have the great pleasure of working with a variety of different members of the community, from our board of directors, our staff, our patient organization members, members of the corporate council who work on developing therapies, those in the research community, all to look at how we can continue to develop programs and services that meet the mission. And when we speak about the mission, NORD's original focus was really to shatter the the current paradigm that existed over 30-something years ago before the Orphan Drug Act was passed, there were issues around health equity back then, despite the environment being very different than it is today. There was really very little chance anybody living with a rare disease would have an opportunity for a treatment or for their disease to be studied or treatment to be developed because the economics just didn't work for those who needed to invest in the community. So the Orphan Drug Act, from my perspective, was one first very big step in trying to address health equity in the rare disease space. However, there's much, much more work that can be done. We have some great successes that we could ride, that wind further, but we have a lot more work to do. And so just so super thrilled to be a part of this conversation and a focused attention on something that is very much needed in the community and in the world as the Rare Disease Day theme for this year really amplifies. Thank you.
Thank you so much, everyone. So as I stated earlier, we did get questions, and we would like to just, get started with that. Several of the people who registered for today's webinar submitted questions related to medical education and how this topic is being discussed by future medical professionals, both in and outside of the classroom. I'm going to direct this to Ashley and Kirk first, but if anyone else would like to engage in the conversation, please feel free to do so. Is this topic part of the medical education in 2021? If not, how can we make sure it's discussed and studied by future medical professionals? Ashley, let's start with you so you can speak from the student perspective, and then we can hear from Kirk, who is involved in the medical education at his institution.
Absolutely. That's a wonderful question. And I think it really speaks to the concern of what our healthcare future will look like. And I'm pleased to say that at the University of Pittsburgh, as well as many universities across the country, there is an emphasis now on the social determinants of health and social justice. And as our class came together to write this oath, these are things, some of the themes that I mentioned are things that we want to see emphasized in medicine in the future. And our school system really supports us with that. We have, different courses such as racism in medicine, as well as, these different themes that run through our interviewing classes and physical exam classes. However, the students outside of the administration also come together to form advocacy groups and interest groups. So some to note, for example, we have an LGBTQIA+ personal enrichment course talking about the disparities there. And so I would say yes. And into the research, it's also seeping into the research world. One program at Pitt's called the Dean Summer Research Program. It's an 8-week intensive kind of research project, and we're implementing now a social piece of that. So it'll be a requirement now where we also show, not only what our research is, but how it can actually be applied in our communities, particularly, focusing on supporting and boosting up these marginalized communities and communities that really are lacking access.
Great, thank you. Kirk, anything to add to that?
Yeah, I think I would echo Ashley's comments on the undergraduate medical education space around the country. It's a similar approach at Mount Sinai, where there is a racism in medicine course and emphasis on the social determinants of health and that real health equity approach to a variety of clinical outcomes and health quality initiatives throughout the medical school experience. I think the one area where we could perhaps do a little bit better at a national level is in graduate medical education under residence and fellowship training programs, and also engaging, attendings, clinicians, providers out in practice, right? And reorienting and ensuring that with the continuous medical education that happens after graduating, we keep up with these lessons, because we are seeing that the medical students are ahead, right, of the rest of the medical profession in really understanding these determinants and the real necessity to address health equity. We really, in fact, many times in many institutions, including our own, a lot of concerns become elevated, brought to the fore, and addressed successfully through advocacy from the medical students. So we'd certainly like to see some of that happening, from leadership, and in a sense it is. I think sort of the events, social justice, racial justice movement from the past year, or the pandemic, has really brought a lot of these concerns into focus. So we're pretty hopeful for the future.
And, you both answered the follow-up question, which was, do you feel that medical education is changing to reflect today's increased awareness of inequities and to ensure that the future healthcare workforce delivers care that is just and equitable for rare and general populations? Do you guys feel that that's happening, or?
I can speak a little bit more to that. I would say that there is definitely a gap in the education surrounding rare disorders. There's not necessarily a lot of conversation. They might just be mentioned in passing. But what I'm hoping to see is more awareness in the curriculum. Even if we just start by getting people thinking about the fact that, it might not be the most common diagnosis. And if this patient doesn't fit in a box, we need to look out, and we need to kind of start looking to the research, looking to the literature, looking to our patients, and really listening to our patients, which I think the medical system, or the medical school system now with the undergraduate education is doing, and pushing for that narrative medicine. But I think a lot of times we're sometimes too focused on diagnosing the test instead of the patient. And so what I'm really hoping to see is more inclusive newborn screening for these rare disorders. And also, part of my mission is really advocacy. So I'm hoping to kind of, hopefully partner with NORD and other rare disease organizations to bring awareness, of rare diseases to, for example, like our interest group. We have a cardiology interest group. We have a neurological interest group. And I'm hoping to bring in speakers that can speak to some of these rare cases and get this awareness and conversation going. So as well as we're doing with the social injustices and racial disparities and other inequities, I think that there does need to be more of a focus on the rare disease community.
Thank you. Kirk, do you have anything to add, or anyone else?
Yeah, I mean, I'll chime in just to completely agree. I mean, we do need a little bit more of a focus on rare communities, rare disorders, and I think that sort of precision-based approach to healthcare that's evolving is an opportunity for us to really crystallize that approach, and also, again, not to forget the inherent inequities that are abundant based on patient characteristics, socio-demographic factors that we constantly have to remind ourselves of.
Alicia, I just wanted to also add that I think it's important for the students to hear from the patients. So having patients actually come to seminars and share their stories, I think helps to make it real life and not something that's abstract because you're reading it in a textbook, so to speak. But bringing those experiences to the students, I think also helps broaden their understanding, their empathy, and therefore their advocacy.
Great, thank you. So the next set of questions are Beverly and Pam, but again, we're all here together. So many of the people in our audience are today are leaders of patient organizations, and they're interested in how their organizations can work to advance health equity. What are the best ways of implementing diversity, equity, and inclusion into an organization's core values, strategic decisions, and operational priorities? And how does an organization not only articulate, but also demonstrate its values?
So I would say that it starts at the top. Many leaders at nonprofit organizations often want to do the right thing, and that's part of the reason why we work for nonprofits. But I think it is important that we are blatantly careful about what it is we want to accomplish. And I think sometimes it starts with an understanding of what is diversity, what is equity, and what is inclusion. Because I think if you were to ask people within your organization for a definition, you would probably get different answers. So I would say that it starts with understanding what those things are. Also looking at language. I believe that language shapes space and it informs, but it also sometimes predetermines how people will treat other people. So I think it's important for us to look at what language we use within our organizations. I would encourage creating guiding principles. Think about how you want to be treated in an organization and extrapolate that to how the organization should treat people of different races, ethnic groups, and backgrounds. I would also encourage building relationships with other cultures and understanding what their lives and experiences are like. I think we make assumptions sometimes about what people do and don't do without having the full background and full understanding and scope of why. And we definitely want to recruit from those who use our services. Sometimes we are looking for people that reflect different communities, but we overlook the very people that are already using our services and could help us come to some better understanding about why we want to embrace them. I would encourage looking at your hiring practices. Where do you advertise for employment opportunities? What vendors do you buy from and do you use? And be intentional about including other cultures, other ethnic groups, and other people into the framework of your organization.
Thank you. Pam, you have anything to add to that?
I was going to say, Beverly said it beautifully. I think to add to that, this notion of implementing those great principles that she described requires communication, better communication, and open-mindedness, which in today's world is more challenging than ever because we live such a fast-paced life. It's just a cycle of immediate gratification, right? So there's no time to think because you're just going, and there's no time to absorb the beauty around you, the differences around you, and the perception that what's in your mind must be right or must be real or must be accurate. So it sounds very simple, but the forces around us have not been working towards the principles and the behaviors that are important to achieve the kinds of goals that Beverly described. So I think, as organizations and as staff, managers, supervisors, leaders, we can show by example if we behave in that way. And also take a step back to try to imagine what a good program that supports diversity or is diverse or achieves its goals, what that looks like, and then work backwards from there. Don't presume you know. Ask the question, how could a program fail? How could it not achieve those goals beforehand? Those are the things I learned in my days of being a patient safety advocate. There's a term called failure mode effects analysis. They use it for product manufacturing and developing programs ahead of time. Where could it fail or where could it miss its marks? Where could it not achieve its goals? And not just assume that the way you're looking at it from the very beginning is the way to success. So I think taking that approach to implementing the principles that Beverly described will really help. And it will also help ensure that, as she said, it starts at the top, but it needs to filter across the entire organization, upwards and down and left and right. And if it does ladder up, if it associates across, then we're lifting the water for all the boats in the bay.
Yeah. And can I add something, Alicia, to what Pam is saying? I think sometimes, and I've heard this so many times with organizations, it's a lot of work. We're busy already. We have a lot of things on our plate. We have clients and patients that need us. But I think if we are honest with ourselves, we would recognize that we do better work when we are inclusive, when our organizations are diverse, when we are representing our communities in the best light. And I would say that sometimes it starts with a conversation at a staff meeting about what are your biases, individual biases, because I think sometimes we make assumptions that we have no biases. And I have participated in activities that really revealed what my biases were and what my stereotypes were about people who didn't look like me. So I think sometimes it's just encouraging conversations within and amongst your coworkers at the water cooler at staff meetings. And again, being intentional about that and being honest about that, I think will be the first steps to helping you become that organization that you envision.
Thank you both. Pam, this question might be better suited for you. Are there organized coalitions at the state level that people could become part of to address issues related to equity within their states?
Yes, there's quite a bit of different activity taking place across the country. One program I happen to know a fair amount is called the Rare Action Network that NORD established across the country. It's really to address this notion of healthcare being very local. I'm sure Kirk and Ashley can speak to that expression. And it's really important because if we're talking about health equity and ensuring access to appropriate care and support services, those are local issues, those are local decisions, those are local barriers. And yes, they may have an association to a national or federal issue, but it all starts at the local level. So people can participate in programs like the Rare Action Network. They vary in their areas of focus, whether you have an interest in addressing policy and working with your state legislative bodies or the departments of public health. Ashley mentioned newborn screening, which will canvass regions across the country. It could be an education-based focused initiative. Rare Disease Day, for example, it's a global awareness day, but there are local events taking place across the country where people can participate based upon the disciplines that are interesting to them. Are you a teacher? You want to bring a rare disease class to your high school or middle school or elementary school program for the day? There's lots of different ways to participate. So we have a website. It's on our website, rather, NORD's website, if they're interested in our state program. And then there are resources on our website about other activities taking place, both for Rare Disease Day and throughout the year.
Thank you. Beverly, a leader of a patient organization submitted the following question. How can we encourage families who identify as Black, Indigenous, and people of color to participate in our organizations? How can we help assume that they are not discriminated against while receiving care?
I love this question because I think it embodies what we've been talking about. I think one of the things that I would encourage leaders to do within their organizations is to understand that it is not, it's a process and it's not basically an end result. It's not about quotas. And I think sometimes that's part of the problem is that we tend to say, well, the community said, we didn't have enough Hispanics, for example. And so we hire one Hispanic person into our organizations and make the assumption that takes care of the problem. And I will tell you, I've experienced that myself. One of the things that we would encourage, I would encourage, is listening sessions. Encouraging your organization leadership or your program staff, your social workers, to participate in listening sessions with people from different ethnic and racial and gender groups, and not be defensive. Because one of the things that typically happens is that when you open the floodgates and you say, well, we want to hear what you really think about us, you have to be prepared to hear what they really think about you. And sometimes it's not nice, and sometimes it's not what you want to hear. But if you go into this space with the thought of, we want to do better and we want to learn and provide programs that are very inclusive, then use the learnings that the community gives you as a way to then benchmark and step into your next realm. So you have to do the research. You have to be willing to listen. You have to forge partnerships with groups that don't look like your organization sometimes. And look at organizations that are also doing it well. We have a lot of roadmaps out there, so we don't have to start from scratch all the time. But look at organizations that are successfully recruiting Black, Indigenous, and people of color, and find out how they did it. What were the lessons learned? And what are the things that you could do to incorporate some of those learnings into your organization? And be transparent about it. So it's not a matter of saying we have all the answers. It's saying we don't have all the answers. We're willing to learn. We're willing to listen. And then we're going to use what we hear from the community to make our organization better.
Great.
Alicia, I'd like to add to that,
Sure.
if you don't mind.
Sure.
Something that occurred to me as Beverly was speaking. One of the few silver linings of COVID-19 is that, look at all of us. We are in different locations. We have learned to be more flexible, to operate hopefully as effectively as we did before when we were coming together in what I'll describe as, bricks and mortar kind of environment. And depending upon where your organization exists, where it got started, it could really create challenges in the past as it relates to recruitment, to Beverly's point. And now we have an opportunity because, organizations have been tested, not, in every instance. Sometimes you have to have, if I'm looking at Kirk and Ashley, where sometimes you have to have the patient and the provider together, physically together. But there's many more opportunities now to not be restricted by organizations' physical presence for recruitment, which is a wonderful thing because it breaks those other barriers, those physical barriers that were a challenge before, that can help us achieve what Beverly described more effectively than ever before. Hopefully.
And I would also add to that, Pam, I think I have had patients who have texted me and called me on a weekend because they've been escorted out by police because they have gone to the hospital seeking care. And they're, considered to be drug users. And it is sad and it is tragic. And I think part of what our mandate, our collective mandate in the rare disease space needs to be is how do we support and raise those issues to the respective entities that need to address them. Because I think a lot of times the patients are looking to us, the leaders within the organizations, for guidance, for support, and for help. And we have to be transparent about helping them address those issues in order for change to happen.
Okay. Thank you. Just one other question in this section here. And Beverly and Pam, either one or anyone on the panel, could you provide any tips, suggestions, or recommendations to a teen on how she can have greater impact in her community or on her community, including her peers, when educating individuals about her rare condition and the disparities and struggles associated with having a rare disease? As a rare disease advocate, how can she communicate the need for health equity?
I love this question, Alicia, because one of the things that we do at my organization is that we have a child and teen ambassadors. And they're actually, they submit an application to be a teen or a child ambassador. And what makes this unique is that they decide within their own hemisphere what they want to do and say to their peers about living with a rare disease. And what I have seen happen, we have a child ambassador right now who started with us when she was 7 years old. She's now, I think, almost 10. And she, within her own groups, have Girl Scout groups and school groups and clubs. She has created her own mechanisms for not only raising money for the walks that we have, but also sharing with her friends, I am living with a rare disease and this is what it looks like for me. And because of her honesty and transparency, she's also been able to garner support from organizations because she's willing to just be honest about what she's living with. And then that then transcends to her friends who say, oh, she's not in school today, or she hasn't been in school for 2 days. She must be having a crisis. And they reach out to check on her to make sure she's okay. So I think sometimes we think we have to start big, but I would say to that teenager, start where you are. Start with your friends, your peers, your family, and use your supports, because a lot of times once you start speaking out, put it on your Facebook page if you have one, if you feel comfortable doing that, you would find that there's so many other kids and teens that gravitate to you because they have not had that platform where they could openly share what they're experiencing.
Yes, and if I could add to that, Alicia, I actually have some personal experience. I started struggling with my rare disease right about 14 years old. And so it was really scary. I didn't know what was happening to myself, to my body. And there was no one I could relate to. I couldn't find anyone else. And, you know, with mine in particular, there wasn't really an organization for it. And I would echo what Beverly said, start small. Talk to someone that you're comfortable with, if it's your best friend or your mom, your dog, even, just to kind of work those words out and explain what's going on. And you know, people are a lot more supportive than you think they will be oftentimes. And exactly what Beverly said, I had that same experience where my friends knew of my rare condition and would reach out when there were issues going on, and just even that support. And as far as the advocacy piece, the biggest piece of advice that I can give you is don't stop. Just because you're young, you're, you know, a teenager, I'm not very far removed from you, can make a huge difference in your community, and people will listen. A lot of times they're tired of hearing healthcare providers preach. They're tired of that, and they want a fresh voice. They want a personal perspective. And so the biggest thing that I can say is just don't stop. You're going to hit roadblocks. You're going to be told you can't. Keep going and reach out to organizations like Beverly mentioned. You know, you have to do a little digging, but even if it's somebody that's not necessarily in the field that you're looking for, shoot out an email, phone a friend, and, you know, kind of reach out to these organizations, and they can point you in the right direction and kind of connect you with other advocates, other organizations. You know, the rare disease world, I'm finding, really is a community. So I just think that's wonderful, hearing other young people wanting to really get involved.
Thank you, Ashley. So we also received questions as it relates to educating current medical professionals. And so one question is, we talked about the education, but many questions were also submitted about current medical professionals. How are challenges related to health inequities being discussed by medical professionals today, and what's being done to address them? Kirk or Ashley?
Yes, I could start, and Ashley could certainly chime in. I think as it pertains to inequities around race, ethnicity, socioeconomic status, I mean, I think, you know, one issue that we are certainly seeing in a lot of academic centers and a lot of healthcare institutions is how difficult it is to get high quality baseline demographic data, right? So race, ethnicity, these are complex characteristics, right? And oftentimes we rely on patient reported characteristics, patients defining their race, ethnicity. But they don't always report that. So, many of us who've been to the doctor, to hospitals with these forms where there's a question about identifying yourself, and many leave that box unchecked or put other. So there's a lot of other documented. So when the quality improvement folks come on the back end to try to look for disparities in clinical outcomes, they often don't have good data to start with. We also know that certain disorders and outcomes are worse for patients with limited access to care, patients of lower socioeconomic status, but that also is sometimes difficult to define. Some of the socioeconomic status scores are related to a zip code where patients live in, but if you're in Manhattan, you'll know, or many other parts of the country, patients can have widely disparate socioeconomic realities, right? Even within that same zip code. So I think there are a lot more sophisticated tools being developed to really pinpoint and identify patient characteristics so that we can better track outcomes. But there is an increasing desire to do so, at least, which is moving the needle a bit from where we've been in the past.
Yes, absolutely. And just to kind of add on that a little bit, one thing that you mentioned was patient intake forms and things like that. And a lot of times all of the marginalized groups are unfortunately grouped together in that other group. And so one thing that we're being taught is, obviously you have to complete the forms, but to have a conversation with the patient once you actually see that form is kind of what they're moving us towards, or even just having those spaces be places to write a little paragraph, what your story is, what you identify, who you identify as, who you are. And also there's, apart from, the kind of more structured way of addressing it, as young medical professionals, we're being pushed to challenge, our fellow students, as well as anyone that we work with in the medical community, and kind of, even though there is that hierarchy and the respect, that it's okay to have that conversation with somebody who's above you. If you see inequities being exacerbated, there's something that's concerning you, there's, language that's not being used correctly. So I think it's really great that the culture is kind of moving more towards open conversations amongst all levels of training.
Thank you. There were several questions submitted related to emergency care and the fact that people with rare diseases often experience inequities in emergency care because of the lack of awareness for their conditions. This sometimes includes, and this goes back to what Beverly was talking about, being accused of drug-seeking behaviors. Do our panelists have any thoughts or suggestions to share related to this type of topic?
Yeah, I guess I could start off. Definitely agree with what Beverly had said earlier, but I would say that the goal would be to keep patients as much as possible outside the emergency room, right? And I think that really should be a safety net, really a last resort. And one would hope that there would be continuity of care with a provider that the patient is comfortable with, communicating any concerns or acute conditions that would arise. And I think that's one issue that's come up with the pandemic, is that we're trying to broaden access to telehealth, right? And even within an emergency context, right? There are now various ways for patients to connect with emergency room doctors via video chat, even before going in physically to the ER. And I think that's also an advance. So I think, the first thing would be to try to reduce the need for a face-to-face encounter in the ER. But beyond that, when it's necessary, of course, we need to better educate our frontline providers about the reality that patients face with rare conditions that may not always be understood. And we do have what we call in-service, training sessions around a variety of disorders and patient-centered communication, and really having that patient-centered care being delivered, and not physician-centered or hospital-centered, but the patient as a priority and the center of it all. And I think that that's been happening also to a better degree.
Yes, and I can just add on to that some experiences with some of the patients that I've worked with. One that was very striking, Pam mentioned working with metachromatic leukodystrophies, MLD, and other leukodystrophies. And unfortunately, some of these kids, when they're towards end of life, they only breathe maybe 4 times a minute. So if these kids are rushed to the emergency room and intubated, a lot of time, they just don't come off of that ventilator. And so parents are actually advised to get a do not resuscitate order for their children, not necessarily so that there's nothing done, but it forces medical professionals to stop, evaluate the situation, and then decide what's needed, because in that situation, that could be life-threatening. The care that's being administered. And so I think it's also really important as healthcare professionals and people just in the community to recognize the struggles, and sometimes, being told that you have to have a do not resuscitate order on your child. I couldn't imagine how crushing that would be. So I think that aside from these things that parents and patients have to do to advocate for themselves, I think that us as healthcare professionals also need to remember to pause, evaluate the patient, in an individual, personalized medicine kind of way before just immediately jumping into whatever the most standardized care would be necessarily.
I also wanted to add, one of the things that I think we can do as advocacy organizations is to also help the patient population understand what their rights are. And so if they're mistreated in the ER or in a hospital setting, understanding what the chain of command is when they're not in a crisis anymore, and making sure that they go back and they, file a grievance, or they share with someone who is an authority figure what their experience has been. Because I think when we talk to patients, many of them say, well, I was just trying to get help. I was just trying to get through this crisis. And then once the crisis is averted, they forget until the next time. And I think it's unfortunate, but I think I agree with both Ashley and Kirk. Education is key. Advocacy is also important. And even like, I've heard from patients who say, well, I feel like I have to dress up to show up at the ER because then I get better treatment. And that shouldn't be, not in 2021 and not in this country.
Thank you. All great points. So we don't have much time left, but I just want to get to a few other questions. Especially now in the midst of COVID's clinical trials. These questions are related to diagnosis, research, and clinical trials, and how to ensure equal representation through all these processes. How do you think we can improve both the diagnostic odyssey and future research participation in underrepresented communities? And this can be open to anyone who'd like to. Maybe Beverly, would you?
Sure. I believe that we know that historically in communities of color, that there have been atrocities that they have experienced as a result of clinical trials and experiments, so to speak. So I think it is important that we first acknowledge those, the history. Also, it's important that we build trust. I think it is important that patients, caregivers feel that they're getting the information from a trusted source, and that their best interest is at the cornerstone or at the forefront of this. Education is important. I think a lot of times patients don't fully understand what is involved in their participation. And I think that the encouragement to be as transparent as possible helps them feel that they're getting all of the information, that they can make educated decisions about participation, and that their families also know, their caregivers also know what they may or may not be encountering. And I chuckle at this, but it's actually not funny. We had a patient who shared with us that he had signed up to be a part of a clinical trial, and he never told anyone in his family, including his wife. And she didn't understand that for months, years actually, what the impact was going to be on their family and on his being away. So I encourage open communication because I think it's important that patients and researchers know what is involved and that they can make an educated decision before they pull the trigger and say, yeah, I'm going to do it. And they not understand what the side effects might be or what some of the obstacles might be to participation.
Yeah, I'm just sort of add in. I completely agree with Beverly. We definitely need to sort of increase trust, right, among communities of color in the clinical trial infrastructure and participation, being representative of the community. Because if we, develop new drugs, devices that are based on studies that don't represent the makeup of our larger society, we won't necessarily know how effective they are, right? And we've seen this in a number of rare disorders in particular, where the recruitment numbers are small, right? Because by definition, these are rarer disorders. So you really do need a sufficient number of individuals from diverse backgrounds represented, because the mechanism of action of the drug and how effective it is can vary by individual patient characteristics. So I think that's crucially important, but we really have to ensure that we're communicating effectively with patients to address any concerns rightfully that they may have about enrolling in these studies.
And then how can we ensure the diversity in clinical trials for people living with rare disease when their disease is uncommon and treatment options and drug development are more limited than with more common diseases?
Yeah, I think just picking up on that as well, venues such as this, organizations like NORD and other, patient advocacy organizations are very, very important. Patient registries, right, where individuals come together and actually understand that for many of these disorders, we don't have effective clinically approved therapy. So one of the best options is to advocate, right, for new, effective, safe treatment. And one of the ways to do this is sort of with numbers, right, banding together, getting colleagues from across the country and the world. And it's a bit easier these days with the web-based platform, social media, various interest groups for specific disorders. But I think that's sort of where it begins, because then you can partner with academic institutions, startups, the pharmaceutical industry, to really develop a safe, effective treatment. And I think that's happened for a number of disorders that really serve as a template for others, where patients coming together, advocating for better treatment options can lead to tremendous success in the clinical realm.
I have 6 practical ways to increase diversity in clinical trials.
There you
go.
The
first one is that I would say we have to widen the eligibility criteria. And that means that study participants actually should be a part of what I think Kirk said earlier, patient-centric focused mandate. So it's not at the phase 3 stage of the clinical trial that you're thinking about what the patients might encounter. It's at stage 1, actually prior to stage 1. The other would be that I think we also need to use community-based centers. Large research facilities, academic facilities are great, but I think we have to come back to the community if you want to engage community. I would say using your patient advocacy groups as benchmarks or stepping stones to helping patients understand what's involved in clinical trials, I think is a good move because they understand the community and they're there. I would say making diversity an internal mandate would be my other recommendation.
Alicia, I was just going to add, and Beverly touched upon it, to what Kirk said. It isn't just about designing a trial and putting words on a protocol that says we're going to recruit, or our goal is to recruit X number of people across this region of the country and these racial and demographic backgrounds. We have to also look at this the system itself and where do we currently and how do we currently recruit patients. To Beverly's point, it's typically not in a community health center. So right then and there that's a gap, that's a hole. There's a lack of friction there, the friction that's needed to initiate recruitment. So I think, taking a systemic view of how we deliver care now, where those interactions are taking place, where are they, are we, falling down, or where are we not, serving the patient community in a way, patients and families, caregivers in a way that can increase enrollment is really important. Perhaps, go to the community, go to them, go to their homes. There's lots of different challenges that exist in the way people live their lives that will not result in the interaction and the friction that's needed to get that recruitment underway. And we have to look at that.
I like that, Pam. I like that a lot, because I think sometimes the companies forget that patients have their own lives and they're dealing with a number of factors, and they expect them to drop everything that they're doing and be in a trial, but they have not considered the obstacles, the barriers, and the ask that patients are having to actually undergo.
Yeah, that's very true. And one of the best pieces of advice I've seen floated around was sort of engaging patients in the clinical trial protocol development, right? Very important to have that patient voice, because some of the screening and other activities could be quite onerous and could be curtailed if they won't necessarily impact the scientific outcome. So that's very important. I think you're on mute, Alicia.
Sorry. Just one more question. Finally, on the topic of which part of our lives for the last several months, the COVID-19 experience was one of the most factors that really brought health inequities to the forefront this year. People in minority communities have been disproportionately impacted by COVID-19. Is there any information on how rare disease community in general has been affected? Pam, I don't know if anybody, did you hear the question, Pam, at all?
I did. Can you hear me okay?
Yes.
Yeah, I lost our connection for a second. I know Nord did a couple of surveys last year, and I know you were a part of that whole process where we looked at the early stages of the pandemic and its impact on the community, and then subsequently several months later. And based upon the conversation that we've had this afternoon and the different areas, the topics, the areas that affect people's lives, how they interact with the healthcare system. If the healthcare system was under siege as a result of this pandemic, it certainly had its impact on the rare disease community. Trials were postponed. People's access to medical care was halted. There were some people who didn't have the ability to pivot to telehealth. People were fearful of going into a hospital. We talked about that. And so it was pretty significant and across the gamut. There were certain areas, certain disease groups where it was more heavily affected. The diseases that had immunological central definition. That's not the term I wanted to use, but I'm trying to speak fast because I know we don't have a lot of time left. But those were very significant impact on them, and they weathered the storm because they're used to dealing with adversity. But hopefully, people are getting back to some sense of normal as much as possible given the current situation.
Well, we've run out of time, and this was a great discussion. We've come to the end of our time, but I want to underscore that this will be a continuing conversation, and we look forward to hosting future conversations related to this topic. We will be sending slides and recordings to everyone who registered for this webinar, and you are welcome to share them with anyone you'd like and that might find it very helpful. I want to thank our speakers for sharing their expertise and experiences with us today. I also want to acknowledge our donors who have made this Rare Disease Day event possible, and I'd like to extend a special thanks to each of you for joining us today. In short, you'll be receiving a survey about this webinar, and we encourage you to complete it. Your responses will help us develop future programs. Thanks again for joining us, and please enjoy the rest of your day. Thank you so much, everyone. Take care.